الكلى بدعوتي للمؤتمر السنوي بتاعهم. مؤتمر ناجح إن شاء الله زي كل سنة وزي ما تعودنا منهم، مليان scientific data ومليان بالورك الهيفي ورك بتاع اللي تعودنا عليه من معهد دمنهور، وعرض النشاط الجميل بتاع المعهد ده. الحقيقة الواحد بيفخر دايما إنه يكون موجود وبيستمتع بالحاجات الجميلة اللي هم بيعرضوها لنا وبيعملوها وشغلهم على مدار السنة، بالإضافة للساينتفك كونتنتس اللي بتبقى موجودة. أنا بعتذر عن عدم وجودي المرة دي لايف معاكم لظروف خاصة، ولكن يعني هحاول إن شاء الله إن احنا نغطي الموضوع في المحاضرة دي. بشكر مرة تانية الدكتور زغلول والدكتورة سلوى على دعوتي. let me go, Mr. Chairman. My talk today is about acute kidney injury in cancer patient. First of all, I would like to go to some epidemiology that about 17.5% up to 27%, nearly 1/4 of cases were reported during the first 5 years of cancer diagnosis to have AKI in this study in 2012. While in different populations in different world, the incidence was much lower, 9.3 in Canada in 2019, and China it's 7.5%. It remains a common complication, reaching up to 9% of patients initiating systemic therapy, and malignancies were found to be associated with the highest 5 rate of risk of acute kidney injury were multiple myeloma, 26%, as you know all, bladder cancer, 19%, and in leukemia. Norbert Lamieux in 2008 found that critically ill patients have acute kidney injury reached up to 60% of cases admitted to ICU. 20% of them had an underlying malignancy. So we can see that the incidence ranges from 10 to 20% approximately. Cases record renal replacement therapy were 8 to 13% in patients with solid tumor and 10 to 34% in patients with hematological malignancies in critical care clinics 2012. The etiology of acute kidney injury in cancer patients is, as usual, etiology, pre-renal or hemodynamic causes. Intrinsic causes, as for example, caused by multiple myeloma and infiltration of tumor cells, as we will see, and obstructive uropathy. So it is pre-renal, renal, or post-renal causes. It may be a direct complication of cancer itself in the form of infiltration or paraneoplastic syndrome, may be related to cancer-related metabolic disturbances such as hypercalcemia or tumor lysis syndrome, for example, or related to treatment such as chemotherapy or immune checkpoint inhibitors, or related to post-stem cell hematopoietic stem cell transplantation. Some cancer-related factors such as monoclonal gammopathies and the AKI, and this is a story that will highlight somewhat in my next slides. Hypercalcemia caused by malignancies, especially multiple myeloma and sometimes other cancers such as cancer prostate. Direct parenchymal infiltration, which is an uncommon process in cancer. It usually presents with bilateral or bilateral enlargement of the kidney, which makes a suspicion of infiltration. Leukostasis such as acute myeloid leukemia or certain lymphatic leukemias, presence of leukemic cells, and aggressive forms of B cells lymphomas can lead to intraglomerular infiltration by these tumor cells. Can manifest as nephrotic range proteinuria, hematuria, kidney enlargement, or severe AKI. So hematologic malignancies are known, the ones known to cause these infiltrations if occurred. Please remember that these are of low incidence to be caused in cancer patients. Again, obstruction is cancer-related factor that causes acute kidney injury. Non-cancer-related factors include factors related to the patient himself at advanced age. Presence of chronic kidney disease, of course, entails an susceptibility to acute kidney injury, diabetes, and concomitant administrations of drugs that affects the renal conditions such as diuretics RAS blockers, antibiotics, or intravenous contrast. These drugs increases the incidence, of course, of any acute kidney injury, including the one we are talking about, a cancer-related acute kidney injury. The pre-renal causes are hemodynamic causes are anorexia and vomiting that are severe in cases of malignancy, causing pre-renal affection, hypercalcemia causing polyuria and pre-renal condition, heart failure, hepatorenal syndrome, affection of the liver by tumor cells, and contrast-induced nephropathy or maybe TMA. This is the spectrum of acute kidney injury in patients with cancer. It may be treatment-related, such as radiation, chemotherapy, hematopoietic stem cell transplantation, drugs such as immunotherapy, targeted therapy, nephrotoxins such as a use of other diuretics, for example, use of antibiotics, crystalline nephropathy, or maybe cancer-related, as I said, glomerular disease, infiltration, which is of low incidence, or obstruction. Here lies the TMA and tumor lysis syndrome, which are in the middle and carries both the characters of treatment-related, maybe occur as a treatment-related form or as cancer-related condition directly. So my agenda in the coming slides will include highlighting specific conditions related to malignancy causing acute kidney injury, such as TMA, tumor necrolysis syndrome, parenchymal infiltration, hematopoietic stem cell transplantation associated AKI, obstructive uropathy, multiple myeloma associated AKI, and the anti-cancer treatment associated AKI. Of course, if I highlighted all of these conditions in details, it will take much more time than that's specified to me. So I will highlight some stress or focus on the important points regarding these important topics in cancer-related acute kidney injury. Let me start by malignancy-associated TMA. This is the TMA all known, and it is the pathological picture does not differ really from the usual picture of TMA, presence of thrombi inside the glomeruli and blood vessels, and the extensive form of TMA. Mechanism of TMA in cancer include intravascular tumor cell aggregates that caused by tumor cell breakdown, which cause decrease in Adams T13. This results in fibrin precipitation in the microcirculation, or may be related to destruction of the vascular endothelium directly, RPC's fragmentation, or alteration of growth factors, including platelet-derived growth factor or vascular endothelial growth factors. This results in microvascular thrombosis. So Adams T13 may be included somewhat in the cases related really directly to tumor cell action, and other factors are also present in the pathogenesis of TMA. TMA can be caused by cancer-related TMA, the tumor itself, or may be caused by treatment. It is important to differentiate, as in cases of chemotherapy-related TMA, we are to stop these drugs or revise our regimen regarding treatment regimens. So is it cancer-related or chemotherapy-related? Usually, in cases of metastatic disease, it is caused by cancer disease, while it may not be present in case of chemotherapy-associated TMA. Clinical phenotypes, cancer-related is usually TTTB-like 4-6% of patients, while ranges from typical HUS to kidney-limited cases in chemotherapy-induced. DIC is known to be caused in 15% of cases of cancer associated, not in TMA-related, while blood picture shows carcinothysemia, carcinoma cell leukemia associated with TMA, disseminated leukoerythroplastic with more significantly elevated serum LDH level in cases of cancer-related. These changes are not present in drug-related. Mean age 65, 40, approximate. Symptom progressive weakness, weight loss, and pain. Median duration of symptoms 21, while 8 days usually after consider after only 8 days after initiation of chemotherapy. Therapy, it failed to respond to plasma exchange in case of cancer-related, and usually we need to treat the cancer itself, while those with Adams T13 response to plasma exchange. As I said, it is responds poorly to plasma exchange, but not that expect to plasma respond the same response to plasma infusion. We need to do a plasma exchange, especially in cases with deficiency of ABD. The cases related to cancer itself needs treatment of cancer and directed treatment to the tumor itself will improve TMA, and no response is expected to occur from plasma exchange. My second condition is tumor lysis syndrome. It is caused by breakdown of large burden of tumor, breaking down of DNA, purine, hypodensity, and then the story you know, and finally the formation of increased serum level of uric acid that precipitates in the tubules, making uric acid crystals and making the process of tumor lysis syndrome. Risk factors include volume depletion and use of other nephrotoxins and hypotension. Excretion of potassium out of Purkinje cells results in hyperkalemia that causes arrhythmias. These are the two drugs that can occur, the enzene oxidase inhibitors, including allopurinol and rasparequase, preventing the formation of uric acid into increasing the formation of uric acid into its metabolites. Cairo Bishop's definition of TLS included laboratory TLS, 2 or more laboratory abnormalities from day 3 to day 7 after initiation of cytotoxic therapy, including uric acid 8, potassium of 6, phosphorus of 6.5 milligram per deciliter, or lower level higher level for lower level for adults, 4.5 milligrams in adults and 6.5 for children, or calcium of 7 milligrams. These are I think these levels are lower levels than you usually met in these cases, much lower level, or 25% of it changes from baseline in any of the above values. While clinical tumor lysis syndrome includes laboratory form, which I was defined previously, plus 1 or more of the following: creatinine 1.5 times the upper limit of normal, cardiac arrhythmias, seizures, or sudden death. These clinical criteria were the basis of gradings of severity of this condition according to Cairo-Bishop grading of tumor lysis syndrome. You can see that it is graded from 0 to 5, and 5 mainly included the most severe form ending in death. Depends on laboratory form, absent, and present in all other 4, absent only in 0 grade, while creatinine less than 1.5, then 1.5, then 1.5 to 3, 3 to 6, and more than 6 times. Cardiac arrhythmias are none in 0 grade, intervention not indicated in 1, non-urgent indication, symptomatic in 3, grade 3, while life-threatening in grade 4. Seizures, also none in 0, not applicable in 1, but 1 brief generalized seizure, and repetitive seizures difficult to control in 3, while status epilepticus intractable seizures in 4. Of course, 5 is the 5th grade, ending in death. Prevention includes fluid intake with initiation of cytotoxic therapy, 200 milliliter per kg per day, or maintaining urine output of about 4 milliliter per kg per hour. If it occurred, please stop. Diuretics and urine alkalinization results in dissolution of uric acid crystals, but precipitation of calcium phosphorus crystals. So another crystals will be deposited. So please, urine alkalinization has no much data to recommend. Other drugs than allopurinol or rasparequase and fepoxistate. Fepoxistate is patients will do not tolerate allopurinol or no access to rasparequase. Other dialysis, please remember that need for dialysis was rasparequase area. Child was 1.5, while adults in 5% cases, same indication as AKI. Early initiation is recommended in cases of acute hyperkalemia conventional, and continuous renal replacement therapy is better tolerated than effective for phosphate clearance, and the combination of both results in rapid clearance and sustained suppression of solids, both phosphorus and potassium. Not recommended to use prophylactic dialysis before the syndrome is established, or to use peritoneal dialysis in these cases. So please avoid peritoneal dialysis in cases of tumor lysis syndrome. My third point is parenchymal infiltration. I said previously that it's mostly of low incidence, known with hematologic malignancy mainly, lymphomas and leukemia. 6 to 6% of cases are caused by lymphomas and leukemia, may cause AKI, new onset or worsening proteinuria, and may cause hematuria. The kidney is enlarged, leukostasis in case of acute myeloid leukemia, and special types of lymphomas, as I said before. Metastases to the kidney are very rare, but occurs in massive tumor burden, carries, of course, a poor prognosis, usually subclinical, presented by hypertension, flank pain, or hematuria. And in this picture, you can see the infiltration of the kidney with multiple cells in the interstitium of the tumor cells in the interstitium. Hematopoietic stem cell transplantation associated AKI. It is defined by doubling of baseline serum creatinine or decline of GFR at least 50% within the first 100 days after engraftment. Carries a high mortality with renal replacement therapy from 55 to 100% cases of mortality. Risk factors including common risk factors: diabetes, hypertension, CKD, sepsis, amphotericin, mechanical ventilation, ICU admission, lung and hepatic toxicity, and the high-risk diseases including acute graft versus host disease, CNIs, non-myeloablative, HCSCT, prior myeloablative HSCT, and CMV reactivation and high-risk disease. Etiology include ischemic injury, direct nephrotoxicity with drugs or viruses, tumor lysis, post-renal obstruction, retroperitoneal fibrosis, lymphadenopathy, hemorrhagic cystitis, maybe Becky cystitis or adenovirus. This is the pathogenesis, vaso-occlusive disease that results in stellate cell activation or endothelial cell damage, portal hypertension, and further glomerular arterial vasoconstriction as a part of hepatorenal syndrome. This may cause acute and results in chronic kidney damage. Other causes of acute kidney injury include acute graft versus host disease, or that initiates in inflammatory cytokines and results in endothelial damage and tubulointerstitial disease and fibrosis. Also drugs, including amphotericin B and viruses, aminoglycosides, CNIs, viruses such as BK adenovirus, cyclophosphamide, tumor lysis syndrome, or these cause tubulointerstitial disease. May also acute radiation nephritis interact with this, resulting in tubulointerstitial disease, hypertension in a malignant way. These are results in acute injury and may result also in later on chronic kidney damage. Obstructive uropathy. Obstructive uropathy can be caused by intrinsic obstruction, which is caused by uric acid crystals in cases of tumor lysis syndrome, or methotrexate crystals or light chain disease, or extrinsic compression that is caused by metastasis, especially in gynecological cancers, retroperitoneal and enlarged lymph nodes, or intrinsic obstruction by viruses, some our blood clots, like virus or blood clots. While on the bladder level, of course, bladder cancer and the prostate cancer represents the main causes of bladder obstruction. Treatment management is treatment of the underlying cancer, of course, and percutaneous nephrostomy. A special entity is called non-dilated obstructive uropathy, which is usually present in malignancy of pelvic areas. There's some form of obstruction that is present without evident dilatation of pelvic calcial system in imaging, minimal or dilatation of biliary tract, and percutaneous nephrostomy leads to rapid renal recovery. Usually, its etiology is not causing obstruction, is encasement of the ureter with tumor or fibrous tissue, abnormal urethral peristalsis, urethral edema, or simultaneous severe volume depletion, in addition of the above-mentioned causes. So please, in unexplained renal failure in pelvic malignancies, obstructive uropathy must be ruled out, even in the absence of pelvic calcial system dilatation on imaging. Coming to myeloma, multiple myeloma-associated AKI, you know that paraproteins, circulating paraproteins, results in tissue deposition, may result in heavy chain, light chain deposition, or amyloidosis, or may result in tubular injury and intratubular cast formation and myeloma cast formation, causing acute kidney injury. Other causes of deposition of light chain or heavy chain may result in glomerular lesion, including monoclonal fibrillary, immunotactoid, or cryoglobulin associated. Acute kidney injury can result from TMA-induced cases or myeloma cast nephropathy or some aggressive form of cryoglobulin-associated diseases caused by deposition disease. This is the classical form of deposition of casts. Multiple myeloma, clinical pathological eosinophilic tubular cast in cast nephropathy, monoclonal cast. This is the FLC free light chains that combines with Damanhour's full proteins, resulting in proteinuria of non-albumin associated proteinuria, or light chain deposition disease resulting in proteinuria and may result in amyloidosis and disruption of the big glomerular basement membrane, causing amyloidosis. Later on, the acute form results of tubular obstruction by free light chain excretion and cast nephropathy. This is free light chain is the basis of the use of hemodialysis and extracorporeal therapy to remove these light chains and decrease the burden on the tubules, decreasing the acute kidney injury states. Coming to this algorithm for treatment, please observe that if we have a free light chain, mainly free light chain diseases, with clinical indication for hemodialysis, clinical indication for chemotherapy, and availability of high cutoff hemodialysis availability. If this is present, okay, we go to biopsy and myeloma deposition disease, early chemotherapy plus high cutoff hemodialysis with monitoring of free light chains. Conventional hemodialysis, if no MCM and no free light chain deposition, then we don't expect free light chain deposition disease and don't expect hemodialysis to lower the myeloma. If no myeloma cast nephropathy, we don't expect it, don't need high cut-off use of hemodialysis. We can use, if no myeloma cast nephropathy, a conventional hemodialysis in the treatment of the condition in cases of indication of presence of usual indication of hemodialysis. We use high cutoff membranes in order to remove the high burden of myeloma cast nephropathy. 4 classes of drugs are used: targeted therapy, immunomodulators, or standard chemotherapy as cyclophosphamide or melphalan, or immune checkpoint inhibitors such as PD-1 and PD-1 ligand inhibitors. These drugs classes of I mentioned in previously carries, some of them carries nephrotoxicity. You can see that cisplatin, for example, it carries ATN and TMA. Melphalan can cause AKI. Cyclophosphamide, hemorrhagic cystitis. All of this can cause, you can observe that acute kidney injury can result from ATN, TMA, for example, acute interstitial nephritis, TMA again, TMA, acute tubular necrosis. These are, most of these drugs can cause by themselves acute kidney injury in addition to the myeloma burden to the kidney. About extracorporeal therapy has been used to enhance the removal of light chains, as I said, but its use remains controversial. No mortality benefit was found from therapeutic plasma exchanges in these studies and is of doubtful value in cases of myeloma. 2 trials are known: European trial of free light chain removal by extended hemodialysis in cast nephropathy in 2019 found that no difference in major clinical outcome among patients did and did not receive high cutoff hemodialysis, while the other study, multiple myeloma and renal failure due to myeloma cast nephropathy, possible reduction in dialysis dependent at 12 months among patients who received the high cutoff dialysis in 2016. This led it to reach this conclusion that high cutoff membranes enhance free light chain clearance in hemodialysis dependent AKI secondary to myeloma cast nephropathy. The advantage of high cutoff use upon standard care is still controversial, but is somewhat enhances free light chain removal. Last point is anti-cancer treatment associated AKI. Cisplatin, for example, can cause intracellular changes, apoptosis, inflammation, DNA damage, and mitochondrial injury. Many of these chemotherapeutics, including statins, methotrexate, gemcitabine, epintrexine, ifosfamide, can cause nephrotoxic effects. You can observe that on acute tubular injury, TMA, acute tubular injury, TMA, acute tubular. So most of them can lead either to TMA or acute tubular injury, or trapezitin can cause, for example, rhabdomyolysis. These are the mechanisms of these drugs to cause acute kidney injury, or of these chemotherapeutic drugs to cause acute kidney injury. Also, growth factors such as VEGF growth factors used recently in cancer treatment, and antibody formation, mTOR inhibitors, all of these can cause multiple forms of renal toxicity. It's not part of our discussion today, but you can observe that TMA, for example, for vascular endothelial growth factors, antibodies, and vascular endothelial inhibitors. TMA again and acute tubular interstitial nephritis can be caused by some of these drugs. Again, TMA hypertension that can be caused by proteasomes inhibitors as a malignant form. Hypertension or pre-renal forms XPO inhibitors. And pre-renal acute kidney injury can be caused in some of these drugs. So also the newly discovered growth factors can cause the AKI by many of these conditions. So my conclusion, Mr. Chairman, AKI is a common problem in cancer patients that adds to morbidity and increases mortality. Cancer-related, it may be cancer-related or patient-related factors, may be related to the disease itself or treatment of the disease, or maybe a combination of both. In some cases, it carries some specific pathologic conditions such as TMA, tumor lysis syndrome, and proper expectation of this condition is important. To yield to proper protection is important, of course, such as proper hydration in case of tumor lysis syndrome, and leads to proper treatment. And thank you very much.